Hello. Hello. Guys, and do you hear me? Yes, everything is perfect besides the fact that you see me instead of the presentation. But I think that will start in a moment. Okay. Okay. That's perfect. You don't have to see my face, as you know. How do I look? Okay, 94 people in here, so I guess we might start in a moment. Let me double check. A couple more people on Discord, so please join us on YouTube. Okay guys, so I will try to follow both Discord and YouTube chat, so you can try ask me questions. If I will know the answers, I will answer. If you will find any troubles in the meantime, just let me know. I will try to follow and repair if it's possible. I am very curious why the WebEx is not working, as it's a commercial type of the connection. But okay, let's get back to the YouTube, which looks fine today. Oops. Yeah, I'd love to open the presentation on my second screen, which is opening on my main screen. So please give me a couple more seconds. And I think I got it. Nope. Voila. Okay, so please just confirm that you hear me and you can see the full screen presentation. Of course, there is delay as always. Okay, so welcome again. It's our third lecture on the pediatric surgery. So I will just make you some confessions on the beginning that this is not my favorite topic, as in our clinic, as in Wrocław, we are a little bit divided into two departments. Our department, which is taking care of mainly congenital diseases in the newborns, and second department from Professor Godziński in the Fildorfa Street, and he is taking care of much more cancers in the time of childhood. However, of course, we also have some knowledge, and I will try my best to provide you as good knowledge as I have. Actually, I was thinking how to prepare myself for today, and I thought that probably we could finish this presentation after 5 minutes. Why I'm saying this? Because we will discuss about couple of diseases, and in every single disease, every single tumor, we will discuss about how to approach such a patient, and we will talk about imaging, about making the biopsy, and the treatment. And actually every single tumor will have different approaches. And actually, from my point of view, from surgeon point of view, it will be mandatory to know when to perform a biopsy, when we can obey the biopsy, and when to perform a surgery. Should it be the first thing which we do, or first there should be, for example, chemotherapy or radiotherapy? And why I'm saying that we could actually finish the presentation after 5 minutes, because what I want you to remember, that in future, every time when you will have a patient, small patient, suspected of having, yeah, I think you can see my face right now. I don't know what happened, but it will be back in a moment, I think. Every time when you will have a patient with a tumor, you have to go to the literature, check current protocols, and decide what approach is good for that very moment, what is the best. I will try to do my best and show you how do we approach in a couple of tumors for that very moment. However, it's not said that in a couple of places that we do it like this, but now the protocols are changing in that very moment. So maybe my knowledge, my speech will be out of date, is even out of date for that moment. So please remember, every time in the future when you will meet such a patient, read the protocols, read the updated data, how to approach such a patient, and what to do step by step. So I guess you can see my face, right? You don't see the streaming. Guys, do you hear me? I mean, do you see the presentation? Okay, so I will send you once again the link to the presentation. Some of you probably already have it. Please download it. And just in case you will not see the presentation on the stream, you will hear me and you can open the presentation. So please open on the slide number first. Okay, so I hope you were able to open the presentation. I think that probably in a couple seconds or a minute, the presentation from my screen will be also in the streaming line, as just these YouTube and OBS have some problems. So let's just skip to the slide number 2, to the epidemiology. In the meantime, if somebody can write me that you are following and everything is fine. So the frequency of the tumors of appearing is significantly lower than in adults. It's the second cause of death under 17 years of age. And generally, those tumors in the childhood are more sensitive to the chemotherapy. These are some general statements on the beginning. And what is more, the chemotherapy in the majority of cases is the most important. It's used almost in all tumors, usually as a preoperative and postoperative treatment and for supporting remission. It aims to make a tumor mass smaller and act on undetectable tumor cells. Surgical treatment is most efficient method of a local treatment, and our aim is to make a total tumor resection. We want to cut off and take out whole mass of the tumor out with the margins, with the clear microscopic margins, and radiotherapy. When we suspect incomplete resection with the microscopic cell remains, and radiotherapy is not so popular as it in the oncology for adults. However, in some cases we will be using it. Yeah, the presentation is back on the YouTube. Guys, I don't know, maybe the coronavirus is, catching even the streaming and making problems with this, because, or maybe, I don't know, maybe so many people around the world are using those streaming lines and it's just not sufficient for everybody. How about occurrence? Every year, about 110-130 malicious tumors on 1 million of children. In Poland, we have about up to 1,300 new cases every year in Poland. Now we are, 5G. Apparently, now we are on the slide with the starting with the word occurrence and the leukemias. What I wanted to show you on that slide, as a pediatric surgeons, we are not taking care of every single tumor, right? I mean, as you know, leukemias in the majority of cases that will be tumors to be cured mainly by the conservative treatment. So we are not strictly bound with the leukemias. However, in the end, I will show you what kind of cooperation with the oncologist, hematologist we have. Central nervous system tumors, they are mainly operated if there is a need for the surgery. Neurosurgeons are helping those kids. And lymphangiomas, sometimes we do operate those tumors. For today, what I wanted to emphasize and what I wanted to discuss about are a couple of tumors which are strictly for us, for the pediatric surgeons. So I'd like to mention about neuroblastoma, the Wilms tumor yeah, we read it Wilms as the surgeon, as the scientist was from Lips, from the Germany. I'd like to talk a bit about sarcomas of the soft tissues and about bones tumor and some other tumors as well. Let's start with the neuroblastoma. Neuroblastoma comes from neuroblast, primary and immature cells of peripheral sympathetic nervous system. The course is variable from spontaneous regression to cause of death. The spontaneous regression is very characteristic for newborn neuroblastoma, which we call 4S usually. But a lot of those cases, especially caught when the tumor is progressed with a metastasis, might be also unfortunately cause of death. Please take a look on the big grade neuroblastoma tumor on that CT scan. It's on the left side. It might be from the adrenal gland. Neuroblastoma is the most frequent tumor of young children. It causes up to 10% tumors in the children. We have up to 10 cases on 1 million children. And please take a look on this. This is important. 50% of the neuroblastomas will be before second year of life. So this is why we call it, this is why we say it's most frequent tumor of the young children. However, the peak of morbidity, so 90% of those tumors of the neuroblastomas will be before fifth year of life. Unfortunately, about 50% of children will have metastasis at the moment of the diagnosis. It's a neuroendocrine tumor arising from any, this is very important, from any neural crest element of the sympathetic nervous system. It differentiates to sympathetic ganglia cells or chromaffin cells. Some histopathology details. So we will have neuroblastoma, ganglioneuroblastoma, or ganglioneuroma. It is very important to have a proper diagnosis from the biopsy to know exactly what kind of tumor we have, but it's not very obvious every time. From macroscopic view, the neuroblastoma has no covering tissue layer or pseudo layer. It's a white, fragile tissue that bleeds easily. Please take a look on that information. Neuroblastoma is mainly in the retroperitoneal space, up to 80%, and 60% of these retroperitoneal tumors will be in the adrenal glands, and 40% will be in the abdominal paravertebral ganglia. What does it mean for us? So 60% out of 80% of the tumor will be in the adrenal glands, which in the big number of cases will force us to differentiate it from, for example, Wilms tumor, right? Which will, of course, we are saying that this is in the adrenal glands. However, please believe me that this is not so obvious when you have such a case, especially when the tumor is big, okay? And please, this is why I want you to remember about differentiating neuroblastoma with Wilms tumor, for example. And how about the rest of the 20% of the neuroblastomas? They might be in the posterior mediastinum, cervical paravertebral ganglia, and pelvic paravertebral ganglia. The metastasis will be to the bones, remote lymph nodes, liver, skin, and other like lungs and CNS. Diagnosis. biopsy and histopathological tests. What is very important that we have elevated levels of catecholamines in urine tests. As I recall, it's in the 90% of patients. And what we do is a biopsy of bone marrow from ileum and the bone. And please take a look on the blue information. What allows us at that moment to set the diagnosis? We have to have positive bone marrow biopsy with a diagnosis of neuroblastoma and elevated catecholamines, or we have to have positive neuroblastoma test from the tumor biopsy. So in the first line you can see that tumor biopsy is not mandatory every time. However, the biopsy is mandatory, but you could have the biopsy from the bone marrow and elevated catecholamines. So in these two situations, as the current book which I have was written, it says that in those two situations we can diagnose a neuroblastoma. What is important? For sure, medical history and physical examination. Blood tests, urine tests, kidney and liver tests. And as I tell you before, in about 90% of the cases of neuroblastoma, levels of catecholamine, dopamine, homovanillic acid, and vanillamandelic acid are elevated. We also perform LDH and ferritin tests, and of course we have to, not of course, but please be advised that you have to perform molecular and genetic tests of tumor tissue. What is more, we have to make an X-ray of the thorax, abdomen, ultrasonography, CT or MRI. It depends on the situation. And scintigraphy of the bones is also very helpful. Symptoms will vary a lot because it depends on the localization. Often you will have fatigue, loss of appetite, fever, joint pain, pallor, weakness, breathing problems, but these are not very characteristic symptoms. In case of the localization in the abdomen, you might see the swollen belly, constipation. Sometimes you might feel the tumor during the palpation. If it will be in the spine, you might have back pain, symptoms of pressure on the spinal cord. If the tumor will be in the thorax, you might have cough, breathing problems, chest pains, dysphagia, and even a Horner syndrome. If it will be in the pelvis, you might find the baby will has defecation disorders, urination disorders. So nothing very characteristic, and might be related to the localization. Of course, as for every tumor, we have some staging systems. For the neuroblastoma, we use International Neuroblastoma Staging System. When in the stage 1 you have localized tumor confined to the area of the origin, and I think that staging, reading those staging for now is not mandatory. However, as the stages rise, the dissemination and of the tumor is higher. And I just want you to take a look on the stage 4S, which means it's not the worst staging. It's something different. Stage 4S is for age beneath 1 year old with a localized primary tumor as defined in a stage 1 or 2 with dissemination limited to the liver, skin, or bone marrow. Less than 10% of the nucleated bone marrow cells are tumors. On the skin, you might see so-called blueberry muffin syndrome. And what is the treatment? The treatment is surgical. We use chemotherapy and radiotherapy, and the order depends on age and staging. What is very, very important, and that will be one of the most important things from our presentation for today, that every time when you perform a surgery, your goal will be to make a total resection of a tumor. You are praying for having total resection and not leaving any tumor tissue inside of the baby. What is more, surgical treatment is also helping you to set a staging. Sometimes you want to make a surgery only for the tumor biopsy, and in the meantime we will discuss about general biopsy rules. And surgery is also for the resection of local lymph nodes or biopsy when they are impossible to remove. What is more, you are marking regions with the titanic clips. Chemotherapy is in the neuroblastoma. The tumor is sensitive to the chemotherapy. It's commonly used, and most popular drugs are written in here. Neuroblastoma might be also radiosensitive and is used to avoid local relapse in a high risk of neuroblastoma, and in the early tumors is contraindicated because can damage, for example, vertebrae. Treatment results depends on the child age and tumor progression. 3-year prognosis in the stage 1, 2 and 4S is even up to 90%, but unfortunately there is not much kids in that stages. Please take a look how worsening is the prognosis in case of children beneath 1 year of age, after 1 year of age. In stage 3 is only 50%, and in stage 4 is only 3 up to 5%. Okay, I don't know if you recall such a situation, because now we will skip to the neuroblastoma, to the Wilms tumor. When the mother is, when the kid is taken a bath, and mother or father during the cleaning the baby is feeling some tumor in the abdomen. In some of the books you will read this as a description of the Wilms tumor. Please take a look on this kid. You can easily see that on the left side of his abdomen there is some tumor, some lump, and as we will reveal it in the future, as we revealed it, that was a Wilms tumor. It's up to 8% of all tumors in children, 7 cases on a 1 million in children up to 15-year-old. In Poland we have about 70 new cases per year, equally in both sexes. And please note that even up to 8% of the Wilms tumor might be bilaterally, and it grows from a differentiated kidney blastoma. Peak morbidity is 3 to 5 years of age, and 80% is below 5 years of age. However, only 10% is before first year, in the first year of age. It's very sporadical in adults. So if somebody will ask you about neuroblastoma and Wilms tumor, you should answer that usually the more neuroblastomas will be earlier than Wilms tumor. So first, neuroblastoma and then Wilms tumor in a little bit older kids. However, also the peak of morbidities for both are before 5 years of age. I'd like you to remember to know that some syndromes are related to the Wilms tumor. Especially, we will think about Beckwith-Wiedemann syndrome, where you have omphalocele, microglossia, hepatosplenomegalia, macrosomia, in Dennis-Dresch syndrome, in Perelman, and in aniridia. Also in VAGR syndrome. What are the features of that tumor? It grows rapidly, usually no symptoms in the early stages, and unfortunately no pathognomic symptoms, and symptoms depend on stage. In the vast majority of those cases, you will see that there is abdominal tumor on the moment of the setting the diagnosis and is having the baby for the first time, which makes increased of abdominal diameter, some kind of pain, others like fever, hematuria, hypertension, and anemia. The kids will be usually in the good general condition. The cachexia is rare, even despite of the large tumor and metastasis. Here you see some pretty small mass of tumor in the right kidney, but this is more common what we see. Please take a look how big the tumor is, covering almost like, I don't know, 70% of the girth of the area of the abdominal cross section. And you have to differentiate that tumor from the neuroblastoma. So for example, catecholamines, elevated catecholamines will be good to differentiate it in the big number of cases, as it's elevated in the 92% in neuroblastomas. You have to differentiate it with the hydronephrosis, kidney disease, and other kidney tumors, but they are rare. Please take a look on this. 85% of the metastasis will be in lungs. Only 10 up to 15% in the liver. I mean, this is not only. However, these are most typical places, and 85% in the lungs. How do we set a diagnosis? This situation is a little bit different because we can have a primary diagnosis. It's based on typical clinical course and imaging. Of course, the final diagnosis will be set after the surgery, after the histopathological specimens and tests, but we can set a primary diagnosis. We can suspect with a high possibility of success of the diagnosis, basing on a typical clinical course and imaging. On the beginning, we use ultrasonography, but what is very helpful is, for example, CT scan, MRIs, and of course we have to perform X-ray of the chest and PET. Okay, I see myself once again, so the presentation is stopped. It's very interesting. I will try to Okay. I turned on reboot the presentation, so maybe it will be online in a moment. However, we are on the slide with the staging of Wilms tumor. So on the first stage, the tumor is limited to the kidney. On the second, tumor extended beyond the kidney. Tumor involvement of the blood vessel of the renal sinus. Third stage is unresectable primary tumor. Fourth is presence of hematogenous metastasis. And five is bilateral renal involvement at the time of initial diagnosis. You don't have to learn it by heart in that moment, but just please remember that there is something like this. And in case of Wilms tumor, we are using in Poland so-called SIOPEL protocol. I will write it in the where is here, which tells us how should we approach to such a patient. And for the Wilms tumor, we are starting with the preoperative chemotherapy. This is very important. The next stage, after we will have a reduction of the tumor mass, we'll make a nephrectomy, whole nephrectomy with a biopsy of local lymph nodes. And once again, after the surgery, we will send such a baby for a post-operative chemotherapy. So I think I see that you don't see my screen. So we are on the slide with the treatment. For the neuroblastoma, we are starting with the preoperative chemotherapy, then nephrectomy, then biopsy of local lymph nodes, and then postoperative chemotherapy. And please change the slide to the hepatoblastoma. I think it's reasonable to mention about hepatoblastoma on that presentation. We have about 15 new cases a year in Poland. It's 75% of neoplasm of a liver in kids. Most of them will happen before second year of age. And what we are doing is we are starting with the chemotherapy, then performing a surgery, which is based on a lobectomy or even a transplantation, and then chemotherapy. If surgery was radical, which means that we cut off whole tumor mass, we haven't left anything inside, we are having 80% of the survival. If the surgery is not radical, if we left something, there is 20% of chances for survival. And what do I mean by asking about hepatocarcinoma in here? It's totally different tumor. Hepatocarcinoma is a characteristic tumor for the adult people. Mainly is connected with the cirrhosis with the alcoholism, with the hepatotropic viruses. And I'd like to discuss one case in here. I will never forget about it, and I'd like to maybe remind it and tell you just how unexpected the life could be, which I'm sure you know so far, but let's discuss one case. So I will never forget the case of the 14-year-old boy who was a soccer player, football player. He went for the camp, and one day he started vomiting. He couldn't stop. He started feeling some abdominal pain, so the teachers went with him to some emergency department, um, and from that emergency department he was transferred to the higher reference hospital. When he went there, the ultrasonography was performed, and they found a great huge tumor of the liver. um, So the camp was stopped. I mean, for him, he was transferred to the Wrocław, to the Przylądek Nadziei, to the hematology department, hematology and oncology, pediatrics department. And the diagnosis was confirmed that there is some kind of big tumor of the liver. And unfortunately, in the imaging, there was a lot of small tumors in the chest, in the lungs. So why I'm telling you that case? Because for the hepatoblastoma, if the chances for survival, the prognosis is better if that hepatoblastoma appears before second year of age, just in the smaller kids. So there was a hope that this young boy, but teenager, not a toddler, not an infant, not a newborn, uh, has a hepatocarcinoma instead of hepatoblastoma. So um, the biopsy was made, the chemotherapy was ongoing, the tumor was getting smaller day by day, and we crossed our fingers for the diagnosis of hepatocarcinoma. But unfortunately, as you probably already figured it out, uh, the kid had a hepatoblastoma. The tumor stopped. The regression of the tumor stopped. So as I told you, I was examining him every day, and for a couple of days the tumor was getting smaller, but finally the regression stopped, and it was like up to the navel, to the umbo. And what we hoped is that the metastasis from the lungs will go away, but they didn't. And 2 weeks later, the boy passed away, unfortunately. So his whole story was closed in about 1 month from the beginning up until his uh, death. So the life is very unexpected. As now we are at the coronavirus, please take a look on that case. So this is why I wanted to, maybe it will be easier for you to remember that hepatoblastoma is more characteristic for the young people, for the young is more characteristic for the young people, for the young kids. Yeah, for the small kids. Please take a look on some example of the hepatoblastoma. And please take a look on in here. Do you have any ideas what kind of tumors we might have in here? Please think about it, write it in the YouTube or in the Discord, and I will be back in 30 seconds. I see no answers. So was there a problem? I was asking, what kind of tumor do you suspect in here? Ah, okay, I forgot you don't see my screen, but I wanted you to skip on the slide where you can see 3 images, 3 photos. I will tell you the number of the slide. It's slide number 44. Do you let me even know if you hear me? Okay, Julian wrote a sarcoma. So on the photo with the arm and the phalanx, it looks definitely like a sarcoma, probably the rhabdomyosarcoma. I'm not sure about the image of the sacrococcygeal area, but we'll discuss it in a moment. Okay, let's skip to the next slide, and one more, sarcomas. It's a large variety of microscopic view staging and malignancy. Because of the large variety of the sarcomas, well, we have problems with diagnosing and treatment. However, please remember that 70% of the sarcomas, of the soft tissues, will be rhabdomyosarcoma. Sarcomas arises from the transformed cells of mesenchymal origin and are made of cancellous bone, cartilage, fat, muscle, vascular, or hematopoietic tissues. Let's skip to the histology. You might have rhabdomyosarcoma, leiomyosarcoma, fibrosarcoma, liposarcoma, synovial sarcoma, alveolar soft part sarcoma, angiosarcoma, hemangiosarcoma, lymphangioma. So a lot of types of sarcomas. Some places in the human body are characteristic for rhabdomyosarcoma, and you can see 2 examples of that characteristic places in here. What are the features of the rhabdomyosarcoma? They might be growing very rapidly and duplicate the mass even in 2 weeks. There is no covering layer, high local relapse, remote metastasis, early metastasis to the lungs, and chemotherapy affects metastasis but not the primary tumor. And sometimes, because of the radiosensitivity, some of them are radiosensitive, and we might use that time radiotherapy. The metastasis leads to provide metastasis to the lungs, bones, bone marrow, CNS, and the liver. Actually, this is very important, so you remember that sarcomas might appear in every part of the body. This is very important because your friends, your patient in the future will come to you with many different type of lumps, and you will be you have to remember that every time you take under consideration possibility of the sarcoma of the soft tissue if it's in a soft tissue. However, typical for RMS, rhabdomyosarcoma, is head and neck, genitourinary system, limbs, chest wall, abdominal wall, and orbits, as you saw. Primary, we will start with imaging such a tumor, and it will push us to think about sarcoma. However, please remember that in case of sarcomas, the biopsy is mandatory. Just a couple hours ago, I was talking with my very good friend from the oncology. He is oncology surgeon, oncological surgeon, and I asked him. Yeah, I know I shouldn't do like this. I will clean it. I asked him if there are situations when you can obey, omit, forget about biopsy in case of sarcomas. He said that no. Every time in case of sarcoma, you should make a biopsy. He said that maybe it's a bit different in case of biology uh, of sarcomas in children. However, generally, I'd like you to remember that biopsy for the sarcomas is mandatory. Of course, in the future, when you will be a doctor, which is very close, uh, read the protocols based on the uh, most proof, most proved scientific resources. However, I'd like you to remember that biopsy for the sarcomas are mandatory. He told me then that in case of adult people, there is only one exception for one type of tumor, and that tumor has to lie just beneath the skin suprafascially. So this is just a one very characteristic time when you can obey the biopsy, but generally just remember that the biopsy is mandatory. In the chemotherapy, we use such drugs like dactinomycin, for example. And how about radiotherapy? If total resection is impossible or no reaction to chemotherapy, then you might consider using radiotherapy. And it's generally not recommended under the third year of life and after total resections. So the idea of the surgery will be to make a total resection. Juciusiu, nie wchodź. Nie wolno teraz tu wchodzić, dobrze? Weź, Iwonko, weź Julcie. Sorry, guys. So you have to know that the tumor you are curing is a sarcoma, and then you have to follow the rules to make a total resection. This is very important, to make a total resection just on the beginning and to make it with the good margins. Prognosis for life without relapse, average 50% up to 80%, but from my experience and my knowledge, those percentage, those prognoses are in a big number, huge number of cases much worse. So it's not good. And I will tell you about how to make a biopsy when we will skip to the tumor of the bones. But for sarcomas of the soft tissue, it will be very important to know how to make a biopsy as well. And a couple of words about so-called sacrococcygeal tumors, which are most seen as a visible mass at birth, making the diagnosis obvious. Actually, I mean sacrococcygeal teratomas. Mainly they will be teratomas. And just notice that it's harder to diagnose when they are intrapelvic. Please take a look on those couple of images in here. You can see a big, huge tumor of sacrococcygeal region, and it's a very demanding surgery. And what is more, it's very demanding because of huge vascularity and the possibility that it will be harmful for the heart, and there might be heart failure and hemodynamic instability after such a surgery. So you have to be well prepared. Couple more images. And here you can see some examples of surgery. And just in a moment we'll skip to the malignant bone tumors, and I will explain you how to perform. I will explain you it on the basis of the bone tumors. However, a couple of rules for the biopsy will be more general. So just to make it clear, what I showed you in here, it's these are teratomas. Okay, I wrote tumors, but I meant teratomas, which is also a tumor, of course. Okay, let's go to the malignant bone tumors. So children bone tumors are mostly benign. However, if you will see, if the diagnosis will be that this is malignant tumor, please notice, please remember, they are very, very highly aggressive. And sometimes you might be fooled by the situation when the tumors are imitating the inflammatory changes. So you have to be cautious. Epidemiology, up to 8% of child tumors, about up to 100 new cases in Poland every year. 60% of them will be osteosarcomas and 25% of them will be Ewing sarcomas. The peak is in the second decade of life, and they are rare under 10 years of life. So let's go to the biopsy technique. The biopsy should be made by the surgeon who will perform final surgery. In the moment when you are doing such a biopsy, you have to plan what will be your way to make a final surgery. You have to choose a place of the biopsy with the help of the imaging. Incision should be longitudinal. Incision should be longitudinal. That is very, very important, as the longitudinal incision will help you to be far from the neurovascular bundle and will help you to make a final surgery. Biopsy should be taken from the edge of so-called Codman triangle. You can see it showed, you don't see my presentation right now. However, the upper arrow is showing the even a little bit higher on the edge of the triangle, which is showed by the arrows. That will be a place for the biopsy, and you have to perform adequate hemostasis to not have a hematoma and not have to reoperate such a baby just only because of the hematoma. Why the biopsy technique is so important? It's so important because you don't want to disseminate such a tumor in the moment when you are performing the surgery. Every time when you are making a biopsy, for example, for the bone tumors, for the soft tissue sarcomas, you want to choose the shortest way. You want to make it oncologically sterile, not spread those cells uh, somewhere else, because then in the next step, when you will be doing your final surgery, you will have to cut off everything. So if you will be forced to put a drainage, for example, you should put the drain in the line of the incision. Or if you have to put it somewhere else, don't put it far. Just put it very, very close to the scar, to the incision, as you will be operating next time, uh, and keeping in mind that you will have to dissect and resect whole the area which might have any connections and will contain the malignant cells. So remember about longitudinal incision, about the fact that you have to plan where to make a biopsy, the fact that you should be the surgeon who will perform the final surgery, or at least make a good consultation before you will be performing the final surgery. And these are a couple of the rules which you have to remember. Unfortunately, there are situations where when we know that, for example, let's say there were let's say there was a tumor of the bone in the or soft tissue in the limb, and because it was done inappropriately, instead of making some reconstruction, the whole limb had to be cut off because of the need to make it radical. So osteosarcoma, let's skip to the next slide, are near to the joints, especially to the knee, even up to 60%, shoulder, elbow, and hip. Please take a look in the next slide. I hope the presentation will be back in a moment. Okay, is it back? Not yet. Okay, however, I'd like to you to take a look on the fibula, on the proximal part of the fibula. Here you can see the osteosarcoma. The thing which you see in front of the knee is just a patella. Please take a look about next images of the osteosarcoma. I think that there is no problem of recognizing where it is. And please take a look also on the scintigraphy, which is showing you the place. And how about Ewing sarcoma? Long bones. So in the osteosarcoma, it was mainly in the area of the joints, and in Ewing sarcoma, Ewing will be mostly in the long bones, but also in the pelvis and spine. It's highly aggressive. It provides a hind bone destruction and infiltration of other local tissues. Up to 20% will provide a metastasis to the lungs, and also to the bone marrow. Unfortunately, 80% of micrometastasis will be undetectable in the CT scans. What will be the symptoms? Pain. It will be also for the osteosarcoma. Pain, especially night pain, fever, local edema, limited movement, trauma, pathognomic symptoms. What I mean by the trauma. So sometimes after even a small trauma, small incidents, there will be a fracture, so-called pathological fractures, which will start the process of diagnosing and suspecting the malignant tumor. So those bones which are not so rigid, not so firm, will might be undergoing fractures more easily. What do we have to do in case of those tumors? So we have to perform X-ray pictures, of course, of the bone, and you can see the bone destruction, damage of the periosteum, and no sharp edges. These are some findings characteristic for the tumor, of the bone tumor. Of course, you should also perform a CT scan or MRIs of the limbs and the lungs, especially of the lungs, and you have to know how disseminated the process is, right? So for sure you are doing a CT and or MRI of the limbs and lungs, and what might be also helpful is scintigraphy. What is also, and actually you are starting with just a normal X-ray, but please remember, this is also very, very important, that every time you have to perform the X-ray in the 2 dimensions, anterior-posterior and from the side. Sometimes you will be able only to see the tumor in the 1 X, so do it in the 2 dimensions, please. And the open biopsy, which we were discussing, is mandatory. What is the treatment? Preoperative chemotherapy, operations, so surgery leading to the total resection, and chemio and radiotherapy post-operatively. And as you can imagine, if we'll cut off a huge part of the bone, we will have to, and you can see it easily in many places actually, but mainly in the middle area. And the next slide is showing a huge destruction, huge mass in the proximal part of the bone. Prognosis. I'd like you to remember for all of the sarcomas that prognosis is generally poor. Of course, we might save those patients. We are curing those patients. However, those tumor sarcomas are very, very aggressive. And let's skip to another slide, X-ray malignancy symptoms. I'd like you to remember that symptoms for the malignancy is osteolysis, periosteal reaction, and cortical destruction. I think that you remember that on the beginning I mentioned that we are not doing much in case of leukemias. However, patients with the leukemias are very frequent in the hematology and oncology departments for the kids, and they need in the majority of cases, actually all of them need some vascular access. I mean, all of them need vascular access. And it's very important that we have to provide them, for a lot of those kids, we have to provide those accesses for a longer time. It's not just a simple IV line. So we need to provide them some permanent catheters, like a Brovec catheters or vascular port. And what will be very important, the technique of placement, implementation of those catheters, it will be the topic for you when you will be learning such a things. However, maintaining and hygiene for those accesses is very important. Unfortunately, I remember the time when it was almost every day that kids were coming from the clinic, from the oncology clinic, because the Brovec was contaminated. There was some infection around, and we had to remove it and put the new catheter once again. So if you will be taking care of such a babies, or you will be, or you will be doctors, or unfortunately you will have somebody around you who is having such a permanent catheter, please strictly follow the all hygiene procedures to maintain those catheters clean. You might use some tapes, you might use disinfection. You have to use disinfection liquids. You should use the sterile gloves, and every time read how to maintain this very specific catheter, how to maintain it. What will be also important, please remember, this is very important, please remember about tumors during your daily practice. You don't know the hour and the day when to your department with some unspecific symptoms, you will have a patient with such a specific symptoms. He will come to you, and you will have to know how to start the process, how to refer such a patient, and the most important is that you should have an idea that the baby might have some oncological issue. I got a question from the Isabella Domenico about PICC line. So the PICC lines are mainly done by the anesthesiologist. However, as every single line, you have to maintain it clean and not allow to contamination. Okay, that's everything from my presentation for today. I will just take a look because my friend sent me a very good materials for you also, but I will just take a look if there is something which I could add you. Give me 2 more minutes. Okay, I will just show you something in here. I think that you can see my screen right now. So please take a look in here. This is leg amputated, and unfortunately there was the scar is transverse in here. There was some tumor in area of knee. I don't even know right now if it was bone or soft tissue. Never mind. However, it was a sarcoma. But the amputation was done only because of badly planned and done procedure on the beginning. What we can read in here is an excision biopsy was attempted without imaging, and popliteal neurovascular bundle was contaminated with what turned out to be a high-grade sarcoma. And in here, another mistake was that the drainage scar and the drain was placed far away from the incision. Here, please take a look. The scar was in the horizontal, and then because we had to cut off, hold this scar, there had to be a big volume of the skin cut off, and then there was a skin graft. Somebody had to put a skin graft in here to cover the layer. So longitudinally, yes, this is how we do it. And what I also wanted to show you in the case of Wilms tumor, please take a look on that belly. It's a very big, the girth is increased, and then we find a Wilms tumor in here. And here is a baby with a bilateral Wilms tumor. Okay guys, that's everything for today. Thank you very much. I tried to do my best, and we will see next week, as I recall. No, next week we will see at 30 of April, and that time I will send you a link to some test. I will give you some time, I don't know, maybe I'm just thinking if we should do it just after the lesson, or I will give you some time to make it. However, please be noticed that on the next lecture I will give you a link to the test. Don't worry, I will give you a very basic question about important things. I know that all of you will pass it. If there will be some problems, don't worry, we will meet again. If there will be a need for this, just please remind yourself the topics which we already had. Thank you, and have a good day, have a good time, stay healthy. Goodbye guys. Thank you. I will take a look on the Discord in a moment. If you will have some additional questions, I will try to answer. I will be there up to 12:45, let's say. Bye bye.